Good morning. I'm Dr. Gaye Carlson, President of the American Academy of Child and Adolescent Psychiatry, with number 24 of my Screenside chats for our AACAP members. This is the one-year anniversary of Screenside chats, and I hope they've been achieving our goal to share timely clinical practice and other information from experts on key topics during the COVID-19 pandemic continuing to plague us. Reminiscent of President Roosevelt's fireside chats during the Great Depression and World War II, I have wanted the topics to be informative, timely, and comfortable, and fill a niche not addressed by materials otherwise available. Today's topic is about another pandemic which actually preceded COVID, but has been exacerbated by it, and that is the topic of what appears to be increasing rates of youth mental illness. Whether it's suicide rates or boarding problems in emergency rooms, which are being increasingly overwhelmed with kids needing urgent attention. I have the feeling that the harder we work, the behinder we get. So my guest today is Dr. David Axelson, who is the Chief of the Department of Psychiatry and Behavioral Health and the John W. Wolfe Endowed Chair in Pediatric Psychiatry at Nationwide Children's Hospital, and professor and the chief of the Child and Family Division in the Department of Psychiatry and Behavioral Health at the Ohio State University College of Medicine. David has shifted his research from phenomenology and treatment of bipolar disorder in kids, which is where I got to know him when he was at the University of Pittsburgh. But since moving to Columbus, Ohio in 2013, his professional focus to the development of a comprehensive pediatric mental health system that can provide high-quality care to a large population of youth has really been seminal to him. He's training the next generation of providers and wants to be able to leverage the system really to perform clinically relevant research. So, David, it seems like over the past few years, more children are presenting to emergency services with mental health crises. The headline in this morning's Pediatrics April 1st journal is Prolonged Emergency Department Length of Stay for U.S. Pediatric Mental Health Visits. The data covers 2005 to 2015, clearly anteceding COVID. What is going on?
Well, Gaye, I think that there's been several studies showing a dramatic increase in the rates of kids presenting to pediatric emergency departments for mental health conditions. An article last year in Pediatrics showed that although ED visits from 2007 to 2016 increased by 11% overall, the visits for mental health disorders increased by 60%. And the visits for deliberate self-harm over 300%.
Wow.
And that leads to the increased wait times that were in the article that was just cited today. And it places enormous pressures on our pediatric mental health system. The number of inpatient beds has decreased actually in many regions, and outpatient services have long wait times for appointments throughout our system. So we've got these kids, who are presenting in crisis to emergency rooms because we don't have a system right now that can adequately address theirs and their families' concerns.
Well, so what do you think? Is it we're having an epidemic of mood disorders? Do we have social media that somehow responds? This is going to be a simple answer that I expect you to say, oh, I know what the problem is. but what are your thoughts about it? I mean, this is what you're doing, and I do think population health is kind of where we have to go. But what are your thoughts about
I mean, it's a great question. I wish we had, more clear data. Certainly there has been evidence that the rates of depression has increased over, the past decade or so. So, a recent study showing that in 2005, the rate of depression in teenagers was about 8.7% for 1 year prevalence, increasing 12 years later to 13%. So that's that's a pretty substantial increase in the population. And as you mentioned, Gaye, suicide, is really a terrible public health problem in our youth. And rates of death and suicide in kids and adolescents increased about 45% in the past decade, and by 2/3, 67% since its recent historical low in 2007. So this is just a dramatic increase. A little tiny bit of good news was that in 2019, which is the latest data that we have, it was the first year that we had since 2007 that there was a significant decrease in the youth suicide rate, with it dropping by about 8.5% from 2017. But it's still the second leading cause of death in kids ages 10 to 19. And, the increase in suicide rate temporarily correlated with, the widespread availability of, cell phones, smartphones. And again, correlation doesn't equal causation, but it does raise concern that the accessibility and omnipresence of social media and electronic devices may not be good for the mental health of our kids and teenagers.
Is it? I used to say that what protected kids and women.
Yeah.
Was lack of knowledge. It used to be, you wonder, well, women get depressed more than men. Why don't they kill themselves more than men? Mm-hmm. And of course, the answer has always been, well, it's because we overdose. We don't shoot ourselves. We don't do things that really are lethal. And I think what has happened has been, now everybody's got loaded guns. You know how to do it right. Women physicians don't make suicide attempts. If we're going to kill ourselves, we know what to do. It's not 10 aspirin, for God's sake. Give me a break, And so I do think that there is some of that's going on. But
absolutely, and what's particularly frightening is the rate has really increased in that age range of 10 to 14. And even, it used to be that there was almost no suicides in kids under the age of 10. Mm-hmm. And now there are some sporadic cases. And it may be a knowledge issue, being more aware of it with social media. Perhaps also it's this, again, it's a developmental issue. 10 to 13-year-olds just aren't ready to be, deluged with all of this information, all of the social consequences of, making mistakes in life and then having it blasted to all the kids throughout, the school, I'm
not ready for that either.
I know. As adults, we're not ready for it. But a 10 or 11-year-old, there's no way. It can be overwhelming for certain, for vulnerable kids, it can lead to tragedy. So I do think we have to be, although again, we can't be dogmatic and say we know what's going on. I think some of the practical, guidance to sort of say, hey, smartphones aren't good for kids, before age 8th grade. Having that constant access and setting some limits, being binged at 11, 12, 1 in the morning is not healthy for our kids. And so we have to, take some practical steps now and see how it works.
How do you think that how has COVID changed things? Has it made it better? Has it made it worse? Has it, it's kept kids away from each other to some extent, but it seems to have made things worse in other areas. Any thoughts about that?
Yeah, and I think it'll be interesting to see as we get more solid data, because we're just now kind of getting a little bit of information. Certainly, anecdotally, some programs are and institutions are increasing a massive increase in demand. It does look like, at least from the published data, and this does sort of match our own experience. When COVID first hit and all the shutdowns shutdowns occurred, in March and April, visits to emergency rooms really crashed, and including for mental health too. There was a big reduction. And then, but the percentage of reduction for mental health was less than for all the medical issues. So actually the percentage of kids were actually more likely if they came into the emergency room, it was for a mental health reason than it used to be. We noticed in our own system, though, that by the summer, we were actually above historic rates. And I don't know if there was sort of a lag but it definitely increased. And a lot of places are saying now that they're at levels that are higher than ever. The system also isn't working quite as well, with COVID, especially in sort of the more kids that need congregate care, inpatient, residential, group homes, with kids testing COVID positive, then they can't move from one place to the other. And so some of our inpatient units I've been hearing, are getting, it's just, we're not able to get kids to that next level of care that might be a little bit less restrictive than inpatient, but still requires, congregate care for kids. So that's been a challenge. There was a nice study out of Houston, showing that that there was an increase in the percentage of kids when they come into their pediatric ED who are screening positive for suicidal ideation and recent suicide attempts. So again, the kids that are getting into our emergency departments seem to have a higher density or sort of impact of suicidality. So I think that we are seeing increased concerns, and certainly there's been some information out there showing that stress has that sort of self-reported stress. And again, these are hard studies to do because there's always referral bias and whatnot, but it does seem to be increased stress on kids and families due to the pandemic. That being said, and again, this is anecdotal, but for some kids, that not going physically to school and doing things with distance learning actually was a better fit for them, and they reported decreased stress and less, and it was for individual cases could be and individual families a better match. So it can be hard to tell, but I know that for a lot of kids, being able to sit in front of a screen and maintain focus for a school day and being engaged, it just wasn't happening, and a real struggle. And what we're going to do, this next year, as we hopefully get back to a more normal situation, is I think we're going to have to be more individualized and thoughtful about, all right, we can't just have everybody in lockstep sort of moving at the same time. Kids are going to be at different places in their development due to this curveball that we've gotten.
I think it may also be safe to say, I work a lot with schools, and to me, school is primary care. School is more primary care than primary care. Yeah. You don't have to go to a pediatrician. You have to go to school. And so I think not having teachers to kind of keep an eye on kids and social workers and schools, they provided a huge amount of mental health help at the entry level. And I think that's not having that there has probably contributed. So what are you guys doing at Ohio State to address some of these concerns? And what do you think sort of in the back of this is, what should we be doing at AACAP to address it? Because I really do think that that's, what is it? This is our wheelhouse.
Yeah.
We should be doing something with this.
Yeah, I'm glad that you raised that, Gaye, because I think that child and adolescent psychiatrists, could really take a leading role. We have really, unique training that puts us, we have knowledge about the biopsychosocial model. We have understanding about, a medical sort of illness approach, but also thinking about therapy, thinking about psychosocial social interventions, thinking systemically. So, you have in some ways an opportunity to take the lead, but it does mean that we have to take the lead, and that can be uncomfortable. And it means probably rethinking our role a little bit, at least having us really see that it's important that, a significant proportion of our work needs to be working in systems, leading and guiding multidisciplinary teams that are responsible for a larger group of kids. We're really seeing the most complex kids, directly, but then guiding the system of care to get kids to the right level of care, and consulting and teaching other healthcare providers about how to manage, more routine psychiatric conditions. And advising those providers that not necessarily could be primary care physicians, could be advanced practice providers, working with the master's level and therapists and psychologists about how to best sort of look at the entire population. Unfortunately, right now, a fee-for-service reimbursement structure doesn't pay very well. It doesn't really pay for that approach. So it's not blaming folks for not being able to do this. This is not and that's where we really need the systems to think differently as well. But better as well as I, Gaye, there's a massive shortage of child and adolescent psychiatrists, and we're not going to, if we sort of try to address this by just cranking out more child psychiatrists, that's probably that's only part of the answer.
It's certainly not going to be enough. I'm not even sure, who you crank out more of. And I think that system approach is something that I don't know. I guess maybe that's what our clinical practice and government affairs folks are attentive to. I mean, sometimes we know that that's what's needed, but the people that need it don't necessarily know they need us. And
that's true.
And certainly the administrative structure in medical schools, that they want your RVUs to be maxed. And so that's the way I feel like, the harder you work, the behinder you get, because it's the feeding somebody a fish as opposed to teaching them to fish model.
Exactly.
And we need to do the teaching them to fish model.
That's right. And, I think one thing that we're trying to do, and, we're early on in this process, but really sort of carve out time to sort of say, our docs are going to spend, 20% of their time doing this more liaison, teaching, advising approach to the system. Where we're very excited, for instance, about and really broadly implementing something called Project Echo, which is a model that was actually developed for better treatment of hepatitis in adults, where there's a hub and spoke model, where the hub is sort of the academic center or sort of the expert center that then does frequent, usually biweekly meetings with in this case primary care physicians, although this model can be extended to multiple different, it doesn't have to be primary care physicians necessarily, but the group of folks out in the community seeing sort of the broader population and doing some brief teaching or lecturettes at the beginning, and then doing really patient-based, case-based learning where, each site talks about the challenging cases that they have and getting advice and consultation, where the hub site isn't, taking on the medical legal responsibility of the kids or the patients, because that's not going to be sustainable. But really, though, providing expert advice that can help improve the care of the kids and of people in the community, and then also help sort of sift the referrals. So actually, there may be somebody that really does need to be seen by the specialty center. Now, of course, it's great with telehealth, and I think, again, one of the silver linings of the pandemic, or there are few of them, but recognizing that actually we can do a significant proportion of our care via telehealth, and we really need to be thoughtful about as we move into hopefully more regular times, what we can still do by telehealth and how we can support the system and be there more for our patients and more for community providers in that way.
So you're talking also then about really changing training, David, because my way of thinking has been that child psychiatrists really need to know how to evaluate the most complicated kids. So we're the Whipple procedure people, okay? Yep. That people need to lance their own boils or whatever. Yeah. But when you need a Whipple procedure, you need to come to the child. So those are the cases that we really need to be able to see and be supervised on. But we also need supervision. And so how to work with a team of people, yep. What to listen for, how to get people working together, for those, I did my training at UCLA back when God was in knee pants. And I remember milieu, how important the milieu was. Mm-hmm. Well, milieus are sort of out, but you know what? They're really important because it's, if people aren't working together cooperatively, then we're not pulling I hate to use all these cliches, but we're not moving the wagon in the same direction. And
absolutely.
So that's one of the things that it seems to me that we may need to do some training in. And I don't know, so are you guys doing that?
We're trying to, we've got some terrific folks who are trying to pioneer this approach. We're not the only place that's doing this. I mean, there's been a lot of great work on pediatric, psychiatry access, but really thinking through an approach where we can kind of be more sustained and a little bit more. I want to say organized or regular about the approach instead of sort of the crisis call approach, really saying, can we have sort of some set aside times and develop some ongoing relationships. The other component that we're adding to this Project ECHO is a psychiatry office hours approach where individual practitioners can sign up for 15 to 30 minutes with one of our docs ahead of time, send just a brief description of the cases that they have, very simple online approach to just sort of giving information and then having consultation and teaching to reinforce that group model that we have with Project ECHO. So sort of the individual and the group component. One sort of interesting thing, and I want to give credit to Dr. Ujwal Ramtekar, who's really done a lot of work with this from our psychiatrists, and Dr. Eric Buter, who's done a lot of work from psychology, is that there's a almost group process to this approach where there's support, other primary care practitioners are feeling supportive of themselves and gaining confidence. The other sort of, special sauce that I might throw out there that we've been able to do with these Project ECHOs is it's not just a psychiatrist who's there. We actually have a psychologist there too, and a social worker, a master's level social worker who has gone out and had liaison with many of the community mental health centers that are in our region, and then really trying to help link up our primary care physicians with those community mental health centers and try to build those relationships. So again, they're not just sort of saying, oh, this is a challenging case, refer to Nationwide Children's Hospital.
Yeah,
which
right,
is sort of,
you take care of it.
Take care of it. I put in the referral. Why is this not taken care of? Well, the family doesn't want to come up here. No. The family doesn't trust us up in Columbus. They do trust the people down in Chillicothe, though. So let's try to get you guys linked up. I know you had some challenges, but let's try to build that relationship. It requires investment. Our hospital is paying for that. Okay. When you talk about what can health systems do, we've got to take this, hospitals got to take this seriously, and they've got to be willing to invest in pediatric mental health and lose some money, frankly. But it's going to actually help the system overall function better. It's going to help our kids get better. And I think we also just need to advocate for better reimbursement management structures.
Well, I think
go ahead.
We follow the money. I mean, there's no question that's
that's where an accountable care organization structure where you're at risk really makes a difference. And we happen to be at risk for about 330,000 kids in Ohio Medicaid. And that allows us to justify, if we can keep kids healthy, if we can treat them earlier on before these problems require kids to be hospitalized or require higher levels of care, we can, it's financially advantageous, and we don't have to worry about billing for it, because essentially we're saving ourselves from having to bill for it in the first place, and it comes out of the per member per month. We may need to move to that model more broadly for us to address these kinds of issues, because the other thing that we're trying to do is really build that continuum of care. I love the fact, Gaye, you're talking about the schools. That is where we need to be putting a lot of emphasis. And, we've been piloting and doing some work with our primary care team to have primary care and mental health, behavioral health in the schools, not having a psychiatrist there, but mental health practitioners, and then the psychiatrist doing telehealth and telesupervision and teleteam building with the primary care team and our mental health professionals. And then sometimes they do need to see the child, but it's a much smaller percentage, and they're also able to hand them back to the, once they've got them doing okay on the stimulant, our primary care APPs there are really engaged and want to help and continue to treat them. And so we're able to see more, yet still get great care working as a team.
Well, I think, it's refreshing to hear you talk about those things. I will watch with keen interest and see if you're able to get the state to support it, because I think it's an important model. I do think we probably need more people all along the continuum, but we also need to use the people that we've got better. So I think we'll end on that positive note. And I am hoping that we'll be able to generate some ideas for our child and adolescent psychiatry AACAP members to be able to develop something similar in their community. So I appreciate your spending time with us, and it's nice to see you again.
Great to see you, Gaye, and thanks so much for doing these. These are wonderful, and thanks for the opportunity.
Okay, and thank you, our listeners. Bye-bye. Thank you all very much for tuning in. This is Gaye Carlson for AACAP's Screenside Chats.
AACAP provides Screenside Chats as a member in public service, but it is neither a legal interpretation nor a statement of AACAP policy. Reference to any specific product or entity does not constitute an endorsement or recommendation by AACAP. The views expressed by guests are their own, and their participation in Screenside Chats does not imply an endorsement of them or any entity they represent. Views and opinions expressed by guests are their own and do not necessarily reflect the views of AACAP or any of its officials.